talk about a very interesting, though quite rare disorder in pediatric practice, one which can have huge implications if it's missed out in clinical practice, that is pheochromocytoma. So, pheochromocytoma is basically a distinct form of endocrine neoplasia, and this has got unique perspective in terms of children. So, how is pediatric pheochromocytoma different from adults, Dr. Alapan?
So pediatric pheochromocytomas are usually presentation is different from the adult one. They usually present like sustained hypertension, while paroxysmal syndromes are much more common in case of adults.
Yeah.
Pheochromocytoma is comparatively rare in comparison to the adult counterpart. And pheochromocytomas are usually bilateral in cases of children. They are much more genetic predisposition is more in cases of children.
So more likely to be bilateral, more likely to be malignant, and more likely to be early onset and metastatic. So Dr. Sandeep, what is the overall outcome as far as pediatric pheochromocytoma is concerned? Is it a good outcome or a bad outcome?
It is a bad outcome.
So generally compared to adults, it may have a better outcome overall, because even if it is metastatic, there are good chances of recovery, which is there. And that becomes important. So the most common presentation for pheochromocytoma is hypertension.
Yeah.
What should be avoided in a child whom you are suspecting as hypertension, and maybe pheochromocytoma is the possibility? Which intervention should be avoided?
Beta blockers should be avoided.
So we should not give beta blockers, because that can really cause a lot of unopposed alpha effect, and that can cause crisis in that perspective. Which genetic disorders are common? So we discussed that it's more likely to be heredity. Which are the common genetic disorders in pediatric pheochromocytoma?
VHL.
So VHL is the commonest as far as the overall pediatric age group is concerned. NF1 would be the second one, and men with usually a later age of onset in that regard. So we are going to talk about pathophysiology of pheochromocytoma, clinical manifestation. Pathophysiology, when we say catecholamine, what does the word catecholamine mean?
Basically, this ring is also known as catecholamine.
Yes.
It is amine that has a catechol ring.
So these are all amines which are derived from this derivative. When we talk about catecholamines, we are talking about dopamine and
Norepinephrine and epinephrine.
So these will be the ones. So dopamine, norepinephrine, and epinephrine. So what is the difference in terms of the source for norepinephrine versus epinephrine?
Epinephrine is exclusively found in the adrenal medulla, because the conversion from the norepinephrine to epinephrine requires PNMT, which is regulated by cortisol, while norepinephrine is found mainly from the nerve endings.
So neurotransmitter, it's basically a neurotransmitter. It's in a way you can say, since chemically they are the same, but the point is that what is the source of production? So one is coming from the neuroterminal and the other is coming from the adrenal. And dopamine, of course, we know is a neurotransmitter from that regards. So when we talk about the entire pheochromocytoma, paraganglioma, we need to understand the sympathetic axis. So these are all neuroendocrine tumors. So they're coming from the sympathetic derivative tumors. And very importantly, they'll be located in different regions of the body, typically in the midline. So they're very, very close to the midline. And if it is in the adrenal, it is known as pheochromocytoma. If the sympathetic chain which is involved, otherwise they are known more like a paraganglioma. So paraganglioma may be anywhere between the neck and it may go up to pelvis, and therefore we'll talk about the manifestations may be different. You may have a glomus tumor which presents mainly as a swelling in the neck region. You may have a lesion in the bladder which may cause hematuria. So sympathetic ones are the ones which are going to cause hypertension, crisis, spell-like episodes. These ones may actually have a local effect. So this will be a paraganglioma, which are more common, particularly in the abdominal region, and 10% may be supradiaphragmatic as well. And they can be both sympathetic and parasympathetic in origin. You can also have head and neck paragangliomas, which are rarer. They are less likely to cause sympathetic activity. They are more likely to cause more of a local effects rather than the systemic effects. So we'll be focusing predominantly about those which have a sympathetic overactivity, because in the truest sense of an endocrine tumor, they will be the ones which will produce either epinephrine or norepinephrine from that regard. As we said, it's a rare one, 7% of all neural tumors and less than 1% of hypertension. Is pheochromocytoma more common compared to the adenocortical cause of hypertension?
It is less common.
Less common. That accounts for approximately 3 to 5% of what is quote unquote a essential hypertension. So anybody who is requiring three or more drugs, anybody whose BP is not getting control, you should screen for pheochromocytoma in that perspective, and also for the adrenal cortical tumors in that regards. So as discussed, all of them have tyrosine as the originating compound. They are all derived from an amino acid, so they are known as biogenic amines. And this tyrosine, the first enzyme activity which is there is tyrosine hydroxylase, which converts it into dopamine, which is then converted into dopamine, and dopamine beta hydroxylase to norepinephrine. So there are multiple activities which are there. The first rate limiting enzyme, of course, is the tyrosine hydroxylase, which is there. And from norepinephrine, as Alapan had talked about, there is an enzyme known as PNMT, or phenyl amine N-methyl transferase, which is going to convert it into epinephrine. And this activity is regulated via the whole process of cortisol. So when we talk about catecholamine, we are talking about dopamine, norepinephrine and epinephrine. Biologically active from a sympathetic perspective are norepinephrine and epinephrine. Which one is more potent, Dr. Nimisha? Norepinephrine or epinephrine?
Norepinephrine.
Norepinephrine will be more active in terms of the cardiac contractility, in terms of heart rate. So actually, when you talk about adrenal process, you know that the adrenal is arranged that you have got the cortex in the periphery, medulla in the center, and you've got the cortisol. There is a radially distributed blood vessel. So when the blood flow increases, cortisol rushes into the medulla and it converts norepinephrine to epinephrine. So from an acute response perspective, epinephrine may be very, very strong in terms of the acute response, particularly the cardiac action. Norepinephrine may be more important from a peripheral vascular resistance perspective. It will be a much more better vasoconstrictor. So when you talk about inotropic, chronotropic, epinephrine will be more vascular resistance. Norepinephrine may be a more potent agent from that regards. Of course, we use norepinephrine more often. So why do we use norepinephrine more commonly in somebody who has shock? So out of these three, all of them are used as vascular agent or vasogenic agents like dopamine, norepinephrine, epinephrine, and of course dobutamine. So what do you think, why do we use, which one do you think is more commonly used? Have you used epinephrine infusion ever?
No.
Why?
They have used
Started dopamine.
So compared to epinephrine, is norepinephrine more potent in terms of blood pressure support?
Yes.
And epinephrine has got a higher risk of arrhythmias. So if you're using epinephrine, that is a major problem. So norepinephrine is more selective for the vessel that way. And Dr. Vibha is absolutely right that dopamine is something which is also started off as the first agent, and then you go from there to norepinephrine, then you go to vasopressin, and there are so many other vasoactive agents which are there. Which is the most potent vasoconstrictor?
Norepinephrine.
Vasopressin? Vasopressin is much more than that, and the other could be angiotensin 2. They are also a very, very strong constrictor. But out of these agents, vasopressin will be a much more potent one, of course, because if you think of it's used in the GI bleeding to really constrict the splanchnic circulation. That is something which is there. Now, as I said, cortisol is essential for conversion of norepinephrine to epinephrine. So many people talk about how do you have hypotension in somebody who has got cortisol deficiency. So cortisol has multiple effect on blood pressure. It has role on sodium regulation, water regulation. But one major mechanism is that your epinephrine response will be blunted if you have cortisol deficiency. So that predisposes to hemodynamic instability. Now, catecholamine essentially would be stored in the form of vesicles because these are the agents you can't wait to produce. So you need to really store them like other peptide hormones. We talked about insulin, PTH. You cannot synthesize them and then release. You want immediate. These are the fastest acting hormones. So they are stored in that, and you also have a chromogranin A granules. Whenever required, they will be secreted. So chromogranin A may be a surrogate marker of production of these agents, like you have C-peptide, like you have copeptin as markers for insulin and AVP. Similarly, you can have CGA or chromogranin A as a marker for catecholamine production. They are, of course, as I said, dopamine and norepinephrine are mainly neural in origin, and adrenal medulla produces epinephrine. So do you think how different is adrenal medulla from a neuron? Is it similar?
It has
The origin of adrenal medulla is neural. So essentially, it's a modified neural tissue only. So it's not, it's a semantic thing, but it has become a form of a gland. So that's why you have got this epinephrine coming in, and that's a specific agent which is coming in from there. Otherwise, the sympathetic neurons will produce your norepinephrine from that perspective. Now, the effects, as we discussed, so we all know about sympathetic effects. So we know the effects are there on the heart, they are there on the blood vessel, they are also on the neuron, then adrenal, and the renin activity is also there. So there are specific receptors which are there for these biogenic amines, including the alpha receptors. Now, alpha and beta may have a antagonistic activity, and that becomes important. So we have got the alpha 1, which is mainly working at pumping of the heart, the contractility part, and it will cause vasoconstriction. So this is the one which is going to cause really your hypertension and other aspects, and therefore the drug prazosin may be quite helpful in this scenario, which is a selective alpha 1 blocker. Alpha 2 has got different activity. It's not working predominantly on the heart, it's affecting the epinephrine, norepinephrine, and it also has some vascular effect. And here, if you use the agent phenoxybenzamine, I'm also trying to put therapeutics here, because when you talk about treatment, which drugs should be avoided, which drugs should be used more commonly, then phenoxybenzamine may be considered as a second line agent, although prazosin would be something which is quite preferable in that regards. Beta has got both beta 1, which is again has a cardiac effect, but predominantly on the cardiac frequency, how fast you are producing that. So contractility and heart rate. And we know atenolol as a blocker there. And beta 2 has got major effect on the blood vessel, but it's a vasodilatory effect. So that's where it's going to help you out from that. So if you are blocking the beta blocker, what will happen? If you give a beta blocker, but you are not blocking the alpha, what's going to happen?
uncontrolled alpha action will lead to.
So let's say you've given propranolol to somebody whom you're suspecting, somebody comes to you with anxiety, tachycardia, and you're given propranolol. What's happening? You said there is an unopposed alpha action. And beta 2 activity or vasodilatation will also be gone. So this is compensating. This is try to, if you think of from a physiological perspective, what the body is doing, it is producing an agent which is increasing your blood pressure, increasing your contractility and vasoconstriction, but simultaneously it's also producing something which is not allowing it to go too high. So your control is very, very tight. But suppose your control becomes loose, suddenly your blood pressure will go up. So that's why beta blocker should never be used selectively in cases where you're suspecting pheochromocytoma. That's a very, very important thing to remember. And dopamine, of course, has a different volume altogether. It's got more role to do with other activities rather than the cardiovascular activity. So it may have some effect. So people talk about vasodilatation, renal perfusion, but that's a minor effect. The major effect is via the epinephrine and renin, and D2 receptor we all know is a prolactin regulator or a prolactin inhibitor from that perspective. So different catecholamines have got different receptors and they've got different action. That's why we can have developed agents which are specific to specific receptors with specific actions from that regards. How do these agents act? What is their mechanism of action? All these catecholamines, they act via the membrane receptor, the cytoplasmic receptor, or the intracellular receptor. Membrane receptor, and largely they use cyclic AMP as an agent, G protein coupled. Typically, epinephrine or epinephrine are cyclic AMP related agents, and if you really have an impact of cyclic AMP blockers, you may have a different function which may happen from that regards. Now, we all know that for prolactin, we have got aripiprazole, which is an antagonist agonist, and we have got cabergoline, which is there, which we use often in terms of treatment of hyperprolactinemia. So now we'll talk a bit about how do we make a diagnosis of these conditions. So we know that dopamine is basically regulated via two main activities. There are two enzymes, monoamine oxidase, MAO, and COMT. So MAO and COMT is involved in converting dopamine peripherally into vinyl mandelic acid. And earlier, VMA was considered to be a very good marker as far as the overall sympathetic activity. On the other hand, if you use the pathway differently also, the COMT and MAO will ultimately produce your vinyl mandelic acid. So VMA is considered a marker of dopamine production, but now we have got better tests which are more sensitive and specific to identify this excess. Very importantly, people use 3-methoxytyramine as a marker of a dopaminergic factor. So if you have high 3-methoxytyramine, you have to start thinking of dopamine from that regards. What about norepinephrine and epinephrine? Again, they have got the same pathway. You've got the COMT and the monoamine oxidase, and you will produce VMA again. So again, they will be there. But in between, there you had methoxytyramine. Here you have normetanephrine and metanephrine. So these are the best agents to look at in terms of the epinephrine production or the norepinephrine production, and they are considered to be markers for adrenergic and noradrenergic ones. I'll talk a bit about which tumors are more likely to be adrenergic, which are more likely to be noradrenergic subsequently from that perspective. But now these are the ones which are better. And when we assess them, we use the fractionated metanephrines. What do you mean by fractionated metanephrines, Dr. Anupam? So you use urine and blood and you say fractionated.
Difference between total and the people.
Yes, so fractionated is simple. It's basically like you talk about all the steroids. You say that you have removed, so it's the free form which you are looking at, not the total form, because the binding issues may be there from that perspective. So between urine and blood, which is better?
If we consider about the sensitivity, they almost have a similar sensitivity, but specificity is better in cases of urine.
So where will you say that, okay, I want you to do a urine, I want you to do a plasma?
Plasma is only done when there is a high probability genetic status is positive.
When you are nearly sure that it is there, if you think about symptomatically and do a plasma, they may be falsely positive. So urinary fractionated metanephrine is generally the best choice. But if it's difficulty in terms of collection, if you are very sure that this is likely to be FEO, somebody is genetically proven, you want to show that there is a FEO now, then you can use the plasma.